My name is Muhamed Baljevic, and I'm Associate Professor of Medicine at Vanderbilt University Medical Center, where I'm a Director of Multiple Myeloma Program and our Amyloidosis Multidisciplinary programs. This ASH is very consequential. There's a lot of interesting and important information and abstracts that have been presented, clinical trials that are given their updates. I'll spend just a couple of moments talking about two different abstracts that I had the pleasure with working with a couple of my colleagues. One of them is on the Selinexor and Pomalidomide and Dexamethasone triplet combination from a STOMP phase 1b/2 study, which looked at patients with relapsed refractory disease and gave this SPD triplet combination in several different fashions. Importantly, it gave it in a weekly fashion with 40 milligrams Selinexor dose or 60 milligrams Selinexor dose, but there was also a cohort which gave 40 or 60 twice a week. So this is really important because Selinexor is perhaps one of the drugs that suffered from a lot of anxiety and lack of experience with some of the more comfortable and tolerable weekly dosing schedules. And this data is actually shedding light on the difference in terms of treatment adverse emergent events as well as efficacy once you actually change the dosing slightly. So what this abstract is essentially bringing to light is the fact that Selinexor, Pomalidomide, and Dexamethasone dosing at 40 milligrams versus 60 weekly achieved better results in terms of safety and efficacy. In terms of safety, there were lower treatment adverse events in terms of severity and frequency. There was also increase in the median treatment duration exposure as well as the intensity of Selinexor dosing that was achieved with 40 versus 60 milligrams. Importantly, even though the numerically overall response rate was slightly higher in SPD 60 cohort, what's relevant is that the median PFS was actually not reached in the SPD 40 versus 9.1 months in SPD 60. So this goes back to that ability of staying on drugs, having less treatment emergent effects, and patients' overall better experience with this lower dosing. This is really important because SPD combination is an all-oral combination of a novel generation immunomodulatory drug and the XPO1 inhibitor. It's a combination that can be potent. It's particularly useful and helpful in management of extramedullary disease because it penetrates also the CNS space, so CNS myeloma can also be treated successfully with this combination of drugs. This has resulted in actually successful planning and ongoing study of SPD 40 in a phase 3 randomized trial versus ilotuzumab, pomalidomide, and dexamethasone in patients with triple-class exposed, previously treated multiple myeloma. So that phase 3 trial will result sometime soon, and we'll see the results of that. So in summary, this is an important piece of data that showcases the lower dosing in terms of strength as well as frequency, which yields a better safety profile, and it seems a better progression-free survival as well.